Everybody, welcome to the first faculty presentation of the Student Surgery Organization. And we are honored to have our advisor today, Dr. DiPasco, here with us. And, I can do a brief introduction. Dr. DiPasco, like I said, serves as our advisor and serves as the current director of the Medical Student Surgery Clerkship, though I imagine that role might be transitioning soon. But I'd turn it over right to you, Dr. DiPasco, and let you do a better introduction that I could do and make sure you can let everybody know what they should know about you.
Sure. Yeah, no problem. And just triple checking, I'm coming through okay. Everyone can hear me? Great. All right. My name is Pete DiPasco. I am a surgical oncologist and an endocrine surgeon here. Although not for long. As Jack mentioned, I have taken another job opportunity to help run a brand new cancer center in St. Louis. And we'll be starting there pretty soon. Actually, November 2nd is my start date. But I've had the proud privilege of being the clerkship director for the School of Medicine and General Surgery Clerkship for the last 5 years. Been on faculty for 8 years total at KU as a surgeon. Prior to that, I was a resident. So 2005 to 2010, did my residency, and then had a surgical oncology fellowship in between those two events in my life. So have quite a bit of knowledge about KU, and certainly have had a lot of great experiences here. I will take the opportunity to announce, because some of you may not know, but there has been new leadership chosen for the surgery clerkship. And by default, that means that they are also liaisons for the Student Surgery Organization. The new clerkship director is Dr. Herman Burbell. Many of you may know Dr. Burbell. He is one of the general surgeons and been with us for about the same time as myself, about 8 years. Has a lot of experience in education, and is really excited to be the director at this point. There are 2 new additional people brought in as associate clerkship directors. And that actually those are positions that we've never had before, actually, since I've been clerkship director. I was kind of the one-man show, but appropriately, we've expanded the leadership ranks. So now the first individual is Dr. Lindsay Kilgore. She's also a graduate of the residency at KU, and that would have been 2018, because she just finished her breast surgical oncology fellowship at MD Anderson and has returned to be faculty member. And she's very educationally minded, really wonderful person. And I know will be very active with your group in particular, because I do think she is the one that's really going to take the true transition of liaison position for me, though you'll interact with all 3 of them. And then finally, the last individual to be an associate clerkship director underneath Dr. Burbell and alongside Dr. Kilgore is Dr. Krista Balanoff. Dr. Balanoff is also an associate program director for the residency, the general surgery residency. And she's acting as a liaison between the residency and the clerkship, and then also an associate clerkship director. I know there's a lot of terms I'm throwing out here, but it's just kind of the formalities of all this. She is also a breast surgeon, and has many years of experience and has a master's in education, and is really a very dynamic and wonderful leader that has proven herself in the residency domain. So now it's really exciting to see her get active in the student domain. So that being said, that transition has already happened. I am not officially the director at this point, which is, kind of strange in some ways, but, exciting in the others, that I know I'm moving on to new prospects and so forth. But all that being said, let's get on with today's activities. Jack, please do correct me if I'm wrong, but to my memory, because I was kind of, partial architect of this type of format, just basically to tell like what it's like to be a surgical oncologist, the pathway to becoming a surgical oncologist, what the average day is like, and what are the kind of pros and cons, or myths and realities of this life that I live. Does that sound about on target to all you guys?
I think that's spot on. And I think to some extent also just to be able to put some clinics or concepts together between maybe what we might be learning in school, some of those cases. And I know for M2s, you had done a CBCL for us or a lecture for us, but, for students that may not have had that experience yet, maybe what are some
Yeah.
conditions that we learn about that you would treat surgically?
Oh yeah.
So,
Yeah. And I'll tell you, I will focus more on the oncology aspects of my career rather than the endocrine aspects of my career. As you mentioned, Jack, my CBCL is a parathyroid CBCL, and so it's really endocrine oriented. But the origin of my training and the lion's share of my what makes me up is cancer surgery. I'm a cancer surgeon, and I'm in fact going to this new opportunity to be even more of a cancer surgeon, doing a whole lot more cases than I am right now. So I'm going to focus on that. So first off, let's just talk about the basics, the real basics. So surgical oncology, let's just define what is that exactly. Well, as the name implies, clearly you are a surgeon who focuses on cancer, okay? And cancer comes in many, many forms. As you know, really any tissue in the body can create a cancer. But as the domain is defined, a surgical oncologist focuses on all of the cancers of the GI tract, the breast, skin and soft tissues, and that includes sarcomas wherever they may be found, whether in the extremities, on the trunk, or in the retroperitoneum. It does include endocrine, just because there are cancers that fall under thyroid and pancreas and all that kind of stuff. Um, what it excludes, what a surgical oncologist would rarely, if ever, do, would be any type of lung malignancies. We would never be doing any lung cancers. We would not be doing any brain cancers or bone cancers, really, because there is such a thing as orthopedic oncology. And many times we do partner together with those types of individuals to work on different types of tumors. But, you know, if you have a basic definition in mind of what a general surgeon does, any of the places that a general surgeon might go in the human body, a surgical oncologist will go there. And in practical terms, in modern practice, practical terms, I always say this: there's nothing that a surgical oncologist would do that a general surgeon couldn't do. Taking a stomach out for gastric cancer, doing a colon cancer surgery, doing a breast cancer surgery. General surgeons across the world do this every single day. It is absolutely within their wheelhouse. The difference here is many general surgeons in modern practice find the complexity and the intensity of those types of advanced cancer cases to be far beyond the resources that they wish to apply to it. And to put that in finer focus, a general surgeon is a very essential portion of a hospital surgical offering. What they provide in terms of hernias and gallbladders and appendix and just general surgical problems that they deal with, that is more than enough to keep them busy. And so many of them willfully say, you know what, I am not going to treat esophageal cancer and do an esophagectomy. I am not going to do a complex colorectal, advanced abdominal perineal resection or something along those lines, because there are other people that specialize in just that and are willing and wanting to put the resources towards it. Not to get too complicated on things, these lines do blur a bit depending on your location. If you're in a major university setting where there's several different subspecialties all lined up within a department, then your general surgeon will be hyper focused on those basic, what are so-called bread and butter general surgery activities: gallbladder, hernia, appendix. Not so in a rural environment or a small community. In a small community, a general surgeon will do most anything, and the only limit to what they will do is rarely the credentialing of the hospital. In other words, the hospital says, you know what, you may be good enough to do a lung surgery, but we don't want that kind of patient recovering in our little hospital. It's too much. We're not going to let you do it. But a general surgeon out in a rural community may absolutely do a Whipple for pancreatic cancer. They may absolutely do a colon cancer. They may absolutely do a breast cancer, or they often do. And even more so, just as an offshoot, they find themselves doing a tremendous amount of just basic GI practice, like a gastroenterologist. They are the only person that knows how to run a scope to do an upper endoscopy, to do a colonoscopy. And if they find anything funky, they usually send it off to, a bigger center. But basic diagnostic gastroenterology, they pretty much do that too. Um, so forgive me, I'm getting a little bit off target here. Back to surgical oncology. The surgical oncologists, we purposefully place ourselves in those difficult cases and those complex situations to try to provide what many others won't. So, as a result, you have to go through the path of general surgery to get to surgical oncology. So, when you graduate from school, you have to go to a 5-year minimum general surgery residency. And I say minimum because some, residencies, as you may have heard, have obligatory research years that might stretch that to 6 years or 7 years. I haven't heard of any obligatory 3-year research programs out there, 5+3. But you go through general surgery and then you go to a surgical oncology fellowship. And those surgical oncology fellowships range from 2 to 3 years. So now at minimum, you are a PGY 7 when you are finished and ready for your first job, if you will. Okay. And that's the path that I took. It was a 2-year fellowship. I went to the University of Miami after University of Kansas for my general surgery. And, a little kind of particular of the field of surgical oncology. Each program has their own uh, kind of proclivity, things that they do kind of better and more frequently than other programs. To give an example, John Wayne Cancer Center in Southern California, they do a lot of melanomas. That's the sun-kissed Southern California landscape that they get a lot of melanomas there. And so they really do a lot of sarcomas and melanoma and breast, and that's just kind of what they do. Pittsburgh is a minimally invasive powerhouse. So they do robotic everything, Whipples and stomach and you name it. Everything is minimally invasive. Florida, Miami, where I went, is foregut. So esophagus, stomach, liver, pancreas, small intestine. That's what they really focus on. And I was very grateful that that was what they did when I matched there because that's what I liked. And that is what I pursued when I finished and was looking for a job. So anyhow, again, you have the ability to go into any of those type of specialties, but most surgical oncologists do kind of find their niche. They find what they really like. The common thread is it's all oncology. You have to be a master of the biology of cancer. You have to understand the concepts of carcinogenesis and mutagenesis and what we do to combat it. Two major concepts that come into play there, of course, the way physicians, I'll be more generic, interface with cancer. We have local therapies and we have systemic therapies. Now, the intuitive contemplations you might have about those two terms are very accurate, I'm certain. Local therapies mean, there's a tumor right here and we're going to cut it out. It's local treatment right there, meaning we're not affecting any bit of the rest of the body. We're only doing one spot. And not only does that mean surgery, but many times that also means radiation. And that's a very close partner, of course, radiation oncology, which we work with all the time to provide local therapy to try and control cancers where they started. Now, the second part, of course, is systemic therapy. That falls largely under the umbrella of medical oncology. And of course, in simplistic terms, that's the administration of chemotherapy. Anything that's administered through the vein will reach any bit of the body, or administered orally in some cases, will reach any bit of the body and will provide systemic therapy to the entire organ system, the entire body system, no matter where that cancer might be. These are very big, important, broad concepts because even if you don't become a surgical oncologist, but you ever treat a cancer patient, there's a very important distinction between a patient who has a diagnosis, which can be managed and cured with local therapy, versus a patient who has need for systemic therapy. If the tumor's gotten out and spread in their body, that's a big problem. It takes more treatment and it's lower risk of lower chance of cure. So those are very important concepts that I certainly want to make sure everyone has an understanding of about, what it's like to think like an oncologist. The other tangent that was talked upon there is these other two groups, radiation oncology, medical oncology. For someone to want to be a surgical oncologist, you have to be exquisitely comfortable with yourself knowing that you like to work as a team. If you are someone that you like to be alone and you don't want to have to wait on anybody else, or you don't want to have to kind of coordinate care and do teamwork and all that stuff, don't become a surgical oncologist or a radiation or medical oncologist either, because you will be constantly at ends with your existence. You have to want to coordinate care across many different people, lots of moving parts, and making sure that everything fits together nicely just at the right time. Surgical oncologists, we're surgeons by nature, and so we wear that proudly. And one of the things that surgeons are certainly proud of is our leadership skills. What I'm about to say is by no means a pejorative statement against medical or radiation oncology, but surgical oncology most often fits into the leadership role. We think of ourselves as, if you will, the quarterback or the air traffic controller that keeps an eye on the big picture. We meet a patient at the onset of their diagnosis. That doesn't mean we're going to operate on them necessarily right away. Many times they have a diagnosis that is so significant that they require systemic treatment prior to any surgery. Not necessarily because they're metastatic, not necessarily because they're, stage 4 or incurable, usually because they're almost stage 4. They're stage 3, and they have what's called locally advanced disease, meaning the lymph nodes surrounding the stomach have proven cancer cells in them. And so it's always a wise decision in that scenario. You meet a patient, you say, let's say you've got stomach cancer. We know that there's lymph nodes involved around the stomach. We're going to give you chemotherapy before you have surgery in the hopes that any cells that exist elsewhere, for instance, the liver or whatever, that we can't see and we don't know about, but they might be there. We're going to give you chemotherapy to try and kill those cells before we try to cure you by cutting this out with a local therapy that is called surgery. Okay. And so that has a special name, and there's a lot of special names in oncology. So, please, and I'll open up the chat thing. If something I say doesn't make sense at all, just type in, what are you talking about? I mean, you don't have to be formal. We have a name for that when someone receives chemotherapy or radiation, for that matter, prior to a surgery, and that's called neoadjuvant therapy. Okay. Also a huge, huge concept. And some of you are shaking your head. You might have heard that topic before, but it basically serves to increase the likelihood that when you go for local therapy, surgery, you are increasing the likelihood that everything is cut out and nothing is left behind, because that's the goal, right? You want all the cancer cells gone. That's how you cure patients. Okay, so we have to coordinate and be that quarterback that meets a patient and says, oh, whoa, whoa, we're at stage 3. You have I'm just going to use some terminology here, a T3N1 stomach cancer, meaning T, it's gone through several layers of the stomach wall. N1 means the nodes are involved, and that means we have to treat you prior to surgery. Okay. So we would actually meet a patient, pass that patient on, and say, we'll see you in about 6 weeks. They go through their chemotherapy. They come back to us. And we say, okay, chemo's done. Let's get some new scans to make sure that nothing's gotten out of control while you've been on treatment. Everything looks good. Okay, let's plan the surgery. We're going to take your stomach out. And then we go through the entire framework of how you live without a stomach. We do the operation. And then we send the patient back to chemotherapy, and they receive more therapy, which is called adjuvant therapy, because now it's after surgery. So it's not neoadjuvant, that's pre. Adjuvant is post. Okay. And so then that patient will undergo adjuvant therapy, but they'll still follow with a surgeon. And one thing that's important and quite different from a practice standpoint of a surgical oncologist compared to lots of other surgeons out there, we follow patients long term. When I operate on an esophageal cancer patient, and I have, had the privilege to do so in the first year I was here, I'm now 8 years, I'm still seeing those patients. And this is a very important aspect of the existence of a surgical oncologist as well. Longitudinal relationships. You don't let these patients go. You've taken them through the most vulnerable and dangerous period of their life. You've built relationships of trust with them, comfort. I mean, it just goes on and on and on. And they never forget that, and they never want to stop seeing you, frankly. And you don't want to stop seeing them. I mean, I will tell you as an aside that those patients that still come to my clinic 8 years after their very dangerous surgery and very dangerous diagnosis, there are far fewer joys that I can think of in my professional career than to just simply see that patient and know they made it to that wedding, they made it to that birthday party, they saw that grandchild get born. It's all these things stack up, and you know that if you hadn't been part of the team to give them chemo, to give them surgery, they wouldn't be there. They'd be gone. So that is something that's quite unique and different compared to, and it doesn't devalue what a general surgeon does. But a general surgeon meets a patient in the ER with a bad gallbladder. Very important. Take the gallbladder out. Patient gets better. They're very grateful. But you don't need to see them the rest of their life. They don't want to see you the rest of their life. They're better. They're gone, and that's it. So you don't have those very very long term relationships. Um, in some ways, it's also been described, not to belabor the point, in some ways, it's been described as almost a hybrid of primary care without the primary care, in the sense that you get to know these patients, you get to know their families, their children, and everything, but you're not managing, their diabetes and their blood pressure and, writing prescriptions and all that kind of stuff. You are watching them from a cancer standpoint, making sure that cancer doesn't come back. And as many of these surgeons are you know, uh, they have lifestyle alterations that come with them. When you have your stomach taken out, you don't eat the same way that you did before, and you have to counsel and kind of help a patient through that for the rest of their life until they really get accustomed to it, which can take years, frankly. Um, so that's kind of the big picture of surgical oncology, and in every way, all of those different facets that I just spoke about are, in fact, the very things that attracted me to the field in the first place. And if you can do some self reflection and realize what are the things that give you joy out of caring for patients, and even more, universally than that, what gives you joy in just human effort. If you like to see the long term results of your efforts, then it's a field for you. If you just want to get the job done as quickly as possible and as well as possible, but let's get to the next one and do another one and do another one and do another one. It's more of a long term game, surgical oncology. As a contrast, just to give an example for someone who might be wondering, I do often think about cardiac surgery as that alternate example I just set there. Um, Many times cardiology kind of gets everything ready for a patient that needs a bypass surgery. And the bypass surgery is completed, and you want it to be perfect, and you want it to be quick, and you want it to be accurate, and all that. But when it's over, it's over. That's back to cardiology, and they manage all of the stuff basically, while the surgeon does another one, another one, another one, and just keeps on going. So it's a different relationship. And I got to watch this firsthand. My father had a bypass surgery about 7 years ago. I think he saw his surgeon a total of 3 times, and that was once pre the day of surgery and once post, and that was it. So it's a very different existence, and you have to know what appeals to you. So that's important. Um, to give you now, I've said a lot there. I'm about to go on to talk about kind of like the average, day in the life type of activity. Jack, Tom, Mitch, Soham, anybody, is there anything that you want me to talk about that I've missed on kind of the philosophies and preambles before I get to the details?
I was just gonna ask you not to be morbid or bring up negative memories or anything, but does that longitudinal
No,
relationship ever, make you more stressed or more because it's a more personal relationship?
certainly.
Things don't always go well. Is that kind of a more stressful thing as well?
So here's the thing, and it's a wonderful question, Tom. It's a very appropriate question. Yes, in a short answer, yes. Stress necessarily isn't the best word because it's all kinetic energy, and it depends on what you do with that kinetic energy. The fact is, these patients, and you don't love them like you love your mother, your father, et cetera, but you care for them deeply, very deeply. And when you see them recur, it's difficult. I had a mentor that told me when I was a fellow, because everybody that gets into this type of business struggles with something like that. And he said, Pete, I know this is hard because I've been there so many times. The only thing that makes me feel better sometimes is I realize, I didn't give him the cancer in the first place. That happened. But what I did was I worked as hard as I could to make things better. And knowing that I'm not the person that can, I'm not the best surgeon in the world. I'm not a magician healer that I can just snap my fingers and people are fixed. I know all I can do is the best that I can to try and provide the best possible outcome. And unless I felt like I didn't do that, then you can't beat yourself up too bad. You have to realize that cancer is a formidable enemy to work on. So it's part of it. I mean, is it difficult? It sure is. But I'll tell you, that's probably not much different than any type of surgery where you actually do risky business, risky type of procedures. Going back into the history of surgery, I mean, 2 centuries. One of the famous French Napoleonic surgeons was quoted, wrote in memoirs that every single surgeon contains in their memory a graveyard of patients that they've lost. And every time they go to operate on a new patient, they walk through that graveyard and they recall all of the things. And while it can, certainly have an emotional weight to it, it's important. It's very important because then you realize what you learn. Not only do you learn from your mistakes and all the technical aspects of this and that, but it allows you to place a bit of compassion and understanding that you've walked through some bad experiences, even though you did the best you could. And it's so funny. I was out to dinner last night with an orthopedic oncologist, Dr. Howard Rosenthal, who is just an amazing man, and I think he's got probably nearly 30 years, if not more, in the field of orthopedic oncology. And we were sitting at dinner last night because I'm leaving soon, and I just wanted to spend some time with him before I went. And he said the very same thing. He said, I know I'm not the best surgeon out there. And he goes, sometimes I've even received patients that have had their cancer recur from what is from a surgeon, that did the first surgery elsewhere that was regarded as the best surgeon in the world. This is the best sarcoma surgeon in the world. And this guy did this surgery and it came back. And I'm thinking to myself, how can I possibly do better than they did? I'm nowhere near as good as this guy. He's an international name. And he told me his mentor at one point or another said, you know what? On the day of that surgery, you're the best surgeon in the world because his knife is not sharper than yours. Um, he did a surgery and it came back. These things happen. That's the nature of cancer. So I hope I'm not getting too kind of diluted in my talk here, but I guess what I'm trying to say all together is you can have some pretty significant disappointments in this line of work, but you have to always walk that fine line that you don't beat yourself up too much about it because that you can only do as much as you can. You're not perfect. You never will be. You can only do the best you absolutely can and know that there are many other factors that are just beyond your control. So a long-winded answer. I hope that gives you the insight, and certainly the Reader's Digest version is any of the disappointments, any of the sad days, any of the emotional challenges, far, far are minuscule by far compared to the joys and the excitement that you have in all the successes that you can provide as a surgical oncologist. And the med onc docs and the rad onc docs feel the same way. I mean, let's face it, we all have disappointing cases, but far more scenarios where you think, wow, we really made a difference here. Look how great this is going, you know? So, great question. Anyone else, Alyssa, or any other questions before I go further?
And Dr. DiPasco, I know you
Yeah.
talked kind of, finding your niche within the field of surgical oncology. What does that look like with like specifically the pediatric population? Is that another, training year, or is that just kind of further subspecialization, or what?
Good question. So there really isn't such a thing as a pediatric surgical oncologist. And the reason for that, number one, thankfully, the need isn't that exquisite. The pediatric cancers, thank goodness, are very, very rare. Who takes care of them, however, are pediatric surgeons. So pediatric surgery, they're regarded by many as kind of like the last vestiges of what surgery originally was before specialization occurred, in the sense that they really do operate on any part of the infant's body. They don't do brain surgery anymore. There are pediatric neurosurgeons, but I mean, head and neck, lung, GI, whatever. They do everything. And it's a different path. You have to go to pediatric surgery fellowship after general surgery residency. There's a whole lot of research you have to do. You're pretty much a PGY 10 by the time you're out of that. It's a long time. So different road. And then, depending on where you practice, many pediatric surgeons are kind of in, average pediatric hospital and kind of do average things. But if you go to St. Jude or some other of the specialized centers, you're going to see a whole lot more cancers. So, any other questions before I just start rambling on day in the life type stuff?
I had a question.
Hey, yeah, what's up?
I sort of related to like sort of the pediatric surgery. How did you kind of carve out your niche in surgical oncology, since you could do like sarcomas, kind of like I think Dr. Maumon does, or you kind of have a very unique set in your practice? So how did you go about developing that?
Yeah, it's like anything else. Sometimes it's coincidence. It all started with my personal interests. I never really had a deep interest in colon and rectal surgery. I never had a deep interest in breast surgery. But the oncology of foregut cancers, of the development of gastric cancers from inflammatory pre-existing conditions, and H. pylori, and reflux in the esophagus leading to carcinogenesis. Those things just intellectually appealed to me. The differences in biology of a sarcoma, how that grows compared to a breast cancer or something like that, just appealed to me. So it was kind of a process of self-declaration. As a surgical oncologist, you're licensed to treat any of these cancers. And if you go to an institution that has need for a surgeon to do those types of cases and you don't say no, you're going to do those types of cases. By the converse, if you go to an institution and you weren't planning on doing a certain type of disease state, but they have a need for it, they will come to you and say, hey, do you mind holding the baton for breast cancer or whatever? And you have the option of saying yes or no. So that's where coincidence kind of falls into it. And my story is a good example of that. I came to KU as a foregut surgical oncologist with no intention of doing endocrine surgery at all. But the endocrine surgeon who was in residence here, who was the faculty endocrine surgeon, he left within 2 months of me arriving. And so the chair literally came up to me in the hallway and said, hey, Pete, can you do endocrine surgery? And it was in my training. I felt comfortable. I had done enough that I knew I could handle it technically. And, as a new surgeon, it's not a bad idea to get busy earlier rather than later. So I said, yeah, I can do endocrine surgery. And so just by pure coincidence, it became a huge part of my practice. And it's like anything else. You get busy in it, you put effort into it, you learn, you grow, and you become recognized as kind of the person for it. So not every aspect of your practice you'll find in your future is by perfect design. I think some of it is by just random chance. Some of it is by design because you just stick to your guns and you have to do a certain type of surgery. That in essence is an example of I'm an example of that in that I am leaving KU. Because as the years went on, I did more and more endocrine surgery, which I loved, but my GI practice, my foregut GI practice, got smaller and smaller. And I realized, if I didn't change course, if I didn't change locations, that wouldn't change. And I wanted that. And so I made it happen. I found it elsewhere, and that's exactly what I'm going to be doing. Um, so that's probably the best answer I could give you on that, Harmony. And I hope that nails it. There's a good
I have a
question in the
quick,
chat
there was
here.
a good
Yeah.
one. Could I ask this follow up really quick before this one gets a little tangential? You mentioned kind of like the incidental shaping, but what about the limitations? So like, for example, you mentioned breast. Usually they go through a breast fellowship, so they can't
Mhm.
necessarily do like as much, but can general surgical oncologists do breast? Is it the other way around?
Oh, absolutely. Yeah. And I will say, it was just from a purely logistic standpoint, it certainly was yet another attraction to why I went into surgical oncology, because there is such a thing as endocrine fellowship. There is such a thing as breast fellowship. There's hepatobiliary fellowship. There's colorectal fellowship. But if you choose those things, you're only going to be qualified to work in those areas. I wanted to be a surgeon that had the capacity to work in all areas if I wished and not be limited in that way. And so personal preference played a big part of that. And as you could probably imagine, it's just kind of a funny thing in the world of oncology surgeons. Surgical oncologists, they don't really boast on it, but they know deep down like they can do pretty much anything. And the endocrine surgeons like usually carry a chip on their shoulder because they don't like to think that anyone thinks less of them. But I mean, they only operate on 3 organs, and it's just a little surgery thing. You can imagine you've seen those types of things in other scenarios. But surgical oncologists, we cover the waterfront. There's no boundaries. We will do anything. So good question. All right. Favorite operation? Yeah, it's kind of one and the same. They're connected to each other. Esophagectomy, gastrectomy. Those 2 operations, the complexity is just high enough, and the satisfaction of being able to remove such a huge important organ, and reconstruct things such that the patient still has a quality of life that is amenable to everyday activities. And in the meantime, taking out a very dangerous and deadly cancer, because both of those cancers are exquisitely dangerous and deadly. It's just very satisfying, very very satisfying. And the little quip joke that I'll add to it is, while a total gastrectomy, nobody really wants their entire stomach removed, but when we do it for cancer purposes, it's important and has its justification. But the quip is, I always enjoy seeing an abdomen without a stomach in it. It's almost like a green space in the center of a congested city. There's just this like glaring gap that just looks very proper but unnatural at the same time. I don't know how to say it else, but it's just kind of a weird thing that surgical oncologists geek out over. So I do. What other questions are out there?
Well, and maybe it'd be better to come back to this once we've talked about the day kind of day in life a little bit. But I'd just be curious to see some of your projections on I mean, you've been here for 8 years, you said, and so how have things changed technology wise or other in that time period? And then as we look ahead the next when all of us will be practicing theoretically, here 10, 15 to 20 years. Do you think that procedures are going to look massively different? Do you think that processes are different, things like that?
Yeah, so a lot of topics to kind of touch on there. It's a good question. You know, I have seen some changes since even in the last 8 years, um, and they really are related to the revolutionary events that have happened in cancer care as a whole. Probably the best example of that I could talk about is targeted therapies, immune therapies and so forth. Um, give you a perfect example: Merkel cell carcinoma. It's a rare soft tissue cancer. Um, Once categorized kind of in the melanoma group, but it's then got distinguished on its own. When I graduated from surgical oncology fellowship in 2012, if you had stage 4 metastatic Merkel cell carcinoma, you were a goner. There wasn't much anything anybody could do to help you. Um, However, in the last 5 years, a monoclonal antibody was repurposed from a different type of, I think it was a lymphoma or something. They just tried it on Merkel cell, cured it. So now, no longer is that a death sentence to have stage 4 Merkel cell carcinoma. That is something I must admit I did not think I would see in my career so soon. I knew I personally, and speaking in very broad strokes, personally, I'm not certain that cancer will be cured, just as a term, in my lifetime. Um, but here I saw basically a deadly cancer cured, and that was something remarkable. So, what does that really mean? Systemic therapy has gotten so good that we are having successes that were dreamt impossible before. Now, does that leave surgeons in the lurch? Meaning, are we going to become obsolete someday if they just treat cancer in a test tube and give them a pill and that's their, you don't need a surgeon? Breast surgery is a very good example that the answer is no. Surgeons will still be useful and relevant in the future. In the history of breast surgery, when someone had a breast diagnosis before there were successful systemic therapies, it was a scorch and burn policy. You took everything. The Halsted radical mastectomy. Breast came off, the muscles came off, everything in the axilla, take everything. As the years have progressed, the decades have progressed, that has gotten to the point now where there are many situations where the surgeon doesn't even need to touch the axilla, any of the lymph nodes at all, which would have been considered heresy 15 years ago, maybe even 10 years ago. But that has changed. However, the breast surgeon still has a very relevant role because the breast surgeon has to decide one size does not fit all. Some patients really need that surgery, regardless of the group. And until the day comes that literally no tissue needs to be removed, the surgeon is still very, very relevant. So I think our role may change slightly. I think that in general, we will certainly be doing less radical type procedures. And what I mean by that is, highly morbid and high mortality type surgeries that really change a patient's body. And we will be doing more minimally invasive type activities as the years go on. Meaning, the old days, they would cut you from here to here and just open everything up, and that's just the only way they did it. But now everything is going minimally invasive, and the history of surgery has shown that every time a more minimally invasive procedure has been proven to be safe, it wins out. The old model just dies out. That's just the way it is, and it will continue that way. If you would indulge me for my own little soapbox, and I don't think it's a conspiracy theory, but some of you may disagree. I think another threat that does pose itself towards surgeons very strongly is that I do think that there are probably only 2 more generations of surgeons, human surgeons, around. You know, the advances in automated technology, artificial intelligence, the precision of robotics at this point, when you can integrate a robotic surgery machine with all of the imaging and all of the anesthesia that's all synergized, we're not going to be able to compete with that. And the common counter argument is, well, the judgment that an experienced surgeon brings to the table is never going to be the same as a robot. Well, here's the thing. Right now, and growing every month, if not every year, if not every month, experienced surgeons across the globe are being studied by artificial intelligence neural networks, watching their surgeries, tracking their movements, all that kind of stuff. We are teaching the machines how we do things right now. And I know this sounds like, like I'm some lunatic, talking about Skynet and all that stuff. I'm not saying that it's going to be, the end of the world. I'm saying I think it's inevitable that at one point a machine will do this job much better than we will. And I think it will probably take 2 more generations of surgeons until it's to the level of safety and availability, that it will actually happen. And my final kind of like pithy statement there is, once a hospital corporate executive realizes that they can purchase a machine that never needs to be fed, that works 24/7 and never complains, they will get rid of surgeons in a heartbeat. Because surgeons throw tantrums and they're expensive and they always want things, and it's just it's gonna happen. It's my opinion. So feel free to throw comments at my position statements, but that is how I feel about things going forward. You guys will be fine, and your children will be fine being surgeons. After that, I'm not so sure. Yes, all the more reason to become one now. I mean, it's exciting time to be a surgeon. Let's face it. I mean, we have things that they couldn't even dream of before. Um, but it does require a surgeon to be a progressive. You certainly can't approach surgery with the mindset of, oh, I'm just going to operate the way they did in the 1950s, because if you do that, you're going to fail. That's not going to work. Have the same internal programs of, how do I make good judgments on who to operate and who not to operate on? Have the internal abilities to uh, recognize your skills and what level they are. And if you need something to be increased, you practice that skill and so forth and all that kind of stuff. That'll never change. Have the compassion to treat people the way they deserve to be treated, instead of, think of it as just a technical exercise. That doesn't change. But all of the technology, all of the mechanisms in which you treat patients, that will change pretty drastically, I think, as time goes on. So it's 12:50. Let me just give you just a very brief overview of the week, of what my week looks like. And granted, mine's a little bit unusual because I do quite a bit in education as well. But I won't go Monday, Tuesday, Wednesday in order. I'll just kind of give it all, and you can kind of get an idea for it. I do have one clinic day a week. It's a full day of clinic. It feeds my practice. I see all my follow-ups and I see all my new patients there. That's where I schedule my patients for the operating room. Usually starts about 8 o'clock in the morning and usually finishes about 6 at night. I operate 2 to 3 days a week, Mondays, Wednesdays, and Thursdays. Those days generally start, I'm arriving at the hospital, and this again, as a faculty surgeon, this is not what it was like when I was a resident. You can have other panels with residents and ask them about that, which I think you have some already. I usually arrive at the hospital about 7, sometimes a little bit earlier, and I'm operating by 7:38. And those days generally go till about 5. Some days are shorter just because of the way things are, happen. But about 5 p.m., I'm about wrapping up my OR, and maybe I'll see a consult or a patient or two before I go home. And I'm usually in the door about 6:30, 7 p.m. Lifestyle wise, kids are early risers, so they're usually up when I'm leaving in the morning. And they're just about going to bed when I get home. So I do get to see my family. I had a conversation with somebody randomly earlier today about, while it may not be wide swaths of time, it's all about the quality of the time that you do get to spend. And so advice I always give to any physician, no matter what kind you are, make sure you're present. When you are home, make sure you're home. Because when you're at work, you're at work. It's hard to concentrate on anything but. When you're a surgeon and you're looking down at the field, you shouldn't be concentrating on anything but. You have to be concentrating on that case. But as best you can, try to at least mentally compartmentalize so that when you do get home, you're present with your family and you're not, somewhere else. Because then that time matters. And that's good advice for just about anybody, I would say. Let's see what else. Fridays are an administrative day, so I try and do all sorts of meetings, research meetings, educational meetings, advisory meetings, all that kind of stuff. Weekends, thankfully, because of the nature of my practice, most of my patients are usually not in the hospital by the weekend. They're usually home. But if they are, I go in and I round and I see them briefly, usually on a Saturday morning. I always say to my patients, you're going to see me on Saturday. You're not going to see me on Sunday. I take one day off entirely for my family and myself. And, if an emergency occurs, of course I'm there, but, unless something's going on, and I just get my report from my residents and whatnot, and manage from afar. And then, rinse, lather, and repeat. That's kind of just happens over and over again. The kind of incidentals that creep into things, when you take on leadership roles, it's nights and weekends a lot of time to complete projects. Right now, I don't see anyone in the room right now, but there are a pretty good number of extremely anxious M4s that are waiting for my letters of recommendation that I'm going to do at my own time, nights and weekends. And I will get them in. But that's just one thing on the to-do list. I have a presentation that's due next Thursday for a national surgical organization. That's, something that'll be taking up some of my weekend. And it looks a lot about what you're doing. You go hit the books, you study, you spend time on your computer, and the actual topic, the work is different, but the time is the same. So all that stuff you've heard about, how when you become a physician, you ascribe to a lifetime of learning, and a lifetime of effort dedicated to that learning and furthering yourself as a physician and furthering the care of your patients. It's true. It's totally true. So, the pace that you set and the feeling, what it feels like to be a hardworking medical student doesn't go away. I mean, what really goes away is that you have more freedom. Or what changes is you have more freedom. As a faculty member, I said I operate 3 days a week and I have one clinic. If I've got something going on, I have to cancel it, I just cancel it. Nobody stops me. As a sad aside, my oldest daughter got diagnosed with type 1 diabetes about a month ago, out of the blue. And I had a clinic and a case and all that stuff. I said, everything's canceled. I have to be home with my family and take care of this. I had the freedom to do that. When you're a student, when you're a resident, it's not that easy. Of course, Dean Meyer and so forth takes care of you and all, but, it's just different. Yeah. As a resident, it's 80-hour work week. And yeah, you can bet you're probably going to be working 80 hours solid every week. As a faculty member, no, I would say it's probably closer to, on the low side, 45, probably on the high side is 60. That's in person at work. Doesn't count what you carve out on your own time on nights and weekends to get things done. But you know what? It's the same as any busy person. It doesn't matter if you're a banker, if you're a farmer. I mean, you're doing stuff when you find time to do stuff and you get the job done. So certainly it's a very livable lifestyle. I don't regret any minute of it. I enjoy it. And again, any of the challenges that I face, those joys of taking care of those patients and seeing them through such difficult, vulnerable times and seeing them successful on the other side outweighs any challenges that come about. And that's never the part that weighs you down. the part that weighs you down is when you feel like you can't get enough done. Sometimes there's just not enough hours in the day sometimes. But then you start to realize, you know what? I can only do as much as I can. And if it doesn't work, it doesn't work. As long as no one's going to die from me not getting that paper in or whatever, then it just has to happen sometimes. You have to understand that. So you know your limitations. Let's see here. A study found that kids only need 20 minutes. I mean, I believe that. I think I I said that random conversation I had earlier today. My father was an internal medicine doctor. I didn't see him in the morning when I woke up. He left early to do his rounds and all that stuff. And when I saw him at night, it was just for a short while. But I can tell you, in no way, shape, or form did I ever feel that I was handed, or I didn't feel that I was that he was not a good father or anything like that. Quite contrary, it gave me a tremendous amount of role modeling for me to see how much he enjoyed his work and how much passion he had for it, and he loved it. And when he was there, he was a great dad. So I mean, I think it doesn't matter what you become, you have the propensity to be busy, and as long as you make the time and make that time count when you have it, then that's what counts. That's what matters. And then the final thing I'll say on that before I open to anything else before we close: don't get too lost in your dedication to your work. And this may sound crazy coming from a surgeon who does all this stuff, but I also realize that everything is in moderation for success in life. And the studies that I've looked at the centenarians, every single one of them consistently, whenever you read a statement from someone who's 100 years old or plus, they don't ever say, "Boy, I wish I spent more time at work." Not one of them. If anything, they say, "I wish I had spent more time with my family. I wish I had, gone on that trip." That's the things that they say. So, that's wisdom. So, yeah, you got to get your job done. Yes, you have the expectations that you have to meet and all that. But at the end of the day, you're going to look back on your life and you have to realize what really matters. So tend to those things. Realize what they are in the first place and tend to them now, while you still have the chance. So, all right. Well, that's 12:59. I think I've philosophized quite a bit for you all. Any other burning, dying questions? Certainly send them off to my email. But I'm not running out. If you guys have any questions, you can shoot them out now or ask them on the chat.
While we're waiting to see if there's any questions, just want to thank you again for all of your service, not just today, but also, I've only, unfortunately gotten to know you in the past couple, about a year and a half or so, but certainly appreciate everything you've done for this group and for students that are interested in surgery. And we will miss you at KU, but we'll hopefully see, maybe we can we'll rent a bus, come on down to St. Louis and come see you or something like that. So
I can guarantee you I'll never turn a student or former student away from my door. And I will further your statements by sending back that admiration. I will say I've been involved with the SSO for even in its prior designation as the SOS for several years, obviously. And the group of leadership that has been around over the last couple years is the finest I've seen. And that's not saying anything bad about the prior. It's just that you guys have really put the jets on. You have just increased the benchmark for what a student surgical organization can do. And I think you should all pat yourself on the back because it's been really quite amazing to watch. And I'm very excited for what you're going to continue to do and your successors with the new leadership at the surgery department. So congratulations to all of you. It's been my pleasure. Please do keep in contact, and I'm not leaving till the end of the month. So if anybody needs me, you know where to find me.
Thanks, Dr. DiPasco.
All right. Thank you guys.
Thank
Have
you
a wonderful
again.
day.
Thank you.
Thank you.
You're welcome.